friends. Today we will focus on nose and temple injections. It will be not too long presentation, but just I want to show you some tricks and some anatomic points and key points. So for a safe injection. So it will be not very long, but very helpful presentation for you, I think. You all know the details about the Algeness. It's a 100% biodegradable injectable implant. We call it as an injectable implant because it has too many advantages and it acts like an implant. But here in nose and in temple, these two things is extremely low migration and not hydrophilic filler. This two is really important for us because in nose injections we don't want swelling, we don't want edema. So hydrocolloid fillers are really has a big advantage in nose. Also, we know that calcium hydroxyapatite is some reaction when touched with the bone and cartilage. So this filler may be the best filler when you use it on bone surface or supraperiosteal plane. And they don't have any migration, and they give really good contouring and projection. So we like it too much in nose. Okay, and in temple, what we need a high G prime filler for a structural support. So Algeness has a very good structural support with its reticular structure. So in these two areas, it's very ideal filler for our practice. You know the injection technique. It's classic for Algeness. It's a linear retrotracing technique. Why? Because when you give it in big bolus way, you can see some lumps. So we don't give it in big bolus injections, not to have a lump. So we try to disperse the product inside the tissues. But in some areas, you will see in presentation, there is some exceptions. Temple is one of them. In temple, we do bolus injection. In nose, we don't do bolus injection. Very small, maybe micro droplets, very small bolus injections. But the main technique for Algeness in whole areas in the face is linear retrotracing injection technique. Before the injections, we need to inform the patients about the limitations and the risk. What I mean with limitations? In nose augmentation, yeah, you can use this filler. You can augment the nose with Algeness, but you cannot reduce the nose with these fillers. So you have to inform your patients about their limitations, and the expectation of patient is really important. And you need an agreed plan, and always take photos and take signed patient consents. Okay. The degradation time. Normally, the degradation of Algeness agarose gel is linear. For 3.5 concentration, it takes 15 months to degrade totally. But in nose, we know that it's much longer. In my practice, 3.5 filler lasts maybe 2 years, maybe more than 2 years. So in nose, the macrophage activity is not too much. So your fillers will last much more longer than other areas. Okay, let's focus to nose corrections. You know, there's two different types of nose injections. One is to camouflage the hump, the deviation, or irregularities. Generally, we inject radix and supratip to hide the hump, and we did some columellar injections to achieve a tip elevation. Okay, so One is these kind of patients. The second one is total dorsal augmentation. In Asian patients, we augment totally the dorsal. So there is two different kind of injections, and let's see. The anatomy is really, really important. The vascular anatomy is really important in nose injections. It's very difficult area and it's very dangerous area. So if you know how to inject and where to inject the injection plane, it will be more safe. Not totally safe, but will be very helpful for you to know the anatomy. Okay. To avoid vessel injury, filler injections into the tip and dorsum should be in the preperiosteal or preperichondrial layers, the subsumous layers. I will show you in a video. And here you can see just a few millimeters above the groove, there is lateral nasal artery. It arises from facial artery. You have to be careful about this lateral nasal artery. And this is another dominant artery of nose. This is dorsal nasal artery. And it arises from ophthalmic artery. And they have so many, 1, 2, 3, oftenly. They have arteriovenous anastomosis between these two arteries and the network between them in the nose. You have to be careful about these plexus and these arteries. The main two arteries is these, and the columella. This is the columellar arteries and branches. They are arising from superior labial artery. This is the main artery of columella. The main arteries of the dorsum of the nose are located at the level of superficial or deep fatty layers. So the lower portion of the dorsum, the nasal arterial branches are located just adjacent to the fibromuscular layer and the deep fatty layer. I will show it in the diagram. And the upper portion of the nose, the level of the superficial fatty layer of the procerus muscle just above the fibromuscular layer. What I mean? Yes, the arteries in the upper nose is here, just between the fibromuscular layer and the superficial fatty layer, here. In the lower nose, it goes a little bit deeper. It is between fibromuscular layer and deep fat layer in the lower nose. This is the dorsum of the nose, and this is artery, you know, and this is in the lower nose. When you go up, it is more superficial here. Sometimes in superficial fatty layer. So don't inject superficially anywhere. And this is columella. For the columellar augmentation, the cannula should be located between two medial grooves. These are medial grooves. And this is the columellar branch, the arteries. This is the skin. So you have to know where to inject. You have to inject between the medial grooves of the lateral alar cartilage, and you have to touch the nasal spine and inject. Okay. Don't inject in front of this cartilage. Don't inject superficially here. Never. And this is the alar rim. You see, this is the alar cartilage. There is main arteries here. One is the oblique artery, alar arteries here, and the one is marginal alar artery. It bleeds too much in rhinoplasty operations, so you have to be careful here at the base of alar rim, and for these arteries, really dangerous place here. Sometimes we inject just above the cartilage because there is a loose plane between the alar skin and the lateral crus of alar cartilage. Just inject here, but I advise you not to inject alar wings. Okay, Algeness is only for midline. Don't go here. I don't advise to inject in alar portion. Yes, this is from a nose operation, rhinoplasty operation. I will show you the place. This is alar medial crucis. You will inject just between them, but I will show you the dorsum. Where is the safest plane? The safest plane is subsimas, we told. What is subsimas? Just over the periosteum and the perichondrium. There is a loose area here. You can see this plane. This plane is avascular plane. There is no bleeding here. You will see, and loose area is loose tissues here. This is the best place to injection. This is subsimas place. Okay. And I take this photograph from a book, but I think for radix injection, this is a wrong injection way. We generally introduce cannula from here and go to the radix. But if the radix is too deep, when you inject this way, you are too superficial to arteries. So I think this is better injection technique to introduce your cannula from the dorsum and go directly to deep. Not from here, but from here. So you have to look how you reach the deepest part of the surface of the skeleton. So you need to inject really deep in this plane. And if you cannot reach this plane with cannula, you can do it with needle. You can just do perpendicular injection and touch the bone and aspirate and give some small boluses. For the columellar injection, you can inject with this way, with cannula. You introduce your cannula, create a hole from intercartilaginous injection between the two alar cartilages in the medial crus and go deeply to touch the spine. You have to touch the nasal spine and then aspirate and then inject your filler. So when you touch the nasal spine, it's really much more safe than soft tissue planes. Okay, this is a very, very difficult case. Why? Because post-surgical deformity of the surface of the dorsum, we just introduce our cannula from here, and we will inject Algeness just to hide the deformities of the dorsum. We inject from here, we do some local anesthesia, lidocaine, and then try to be at the supraperiosteal and supraperichondrial plane very deeply. And you see, I am now doing some detachments, some subcisions before injection. If there is fibrotic tissues, first of all, you have to dissect them to create a space for injection. This is very essential in all kinds of fibrotic tissues or post-surgical injections. You have to dissect the injection area. After you finish to dissect the area and create a whole space for injection, you will aspirate and linear retrotracing injection on the dorsum, okay? This is really difficult case, and I want to show it. Why? Because we use here 1.5 agarose gel concentration. Normally, in nose, we use 3.5 and 2.5, but this patient has very thin skin and very complicated nose, so So we prefer to use 1.5. So you can use all kind of concentrations. It depends on the thickness of the skin and the problems of the area. And now we inject for camouflage. You will see now. Yeah, she needs some tip elevation, but I think it will be with surgery, not with injections. So we hide the deformities in the dorsum, and I always advise to tape the nose after injection. I think it's really helpful for us to prevent from swelling and migration. And when we inject to the dorsum of the nose, we just give pressure with our fingers to the lateral sides of the wall of the nose to pressure the vessels, and it reduces the migration. So always we press with non-dominant fingers to the lateral walls of the nose. Okay, we will tape now, and the day after you can remove it. Just the same day with injection, and the day after you can remove all the tapes, no problem. You have to sterile in a very asepsis conditions. It's very important because we do massage, we do molding, so we use our fingers too much. So to prevent from contamination, you need to work in really asepsis conditions. Okay. Now, what we did this in these patients from photographs, it's really difficult to see, but there is too many deformities in the surface of the nose. Here, some depressions, you see, some depressions, and here you can see the cartilage and bone, and we just do camouflage. Here you can see some creases, some cartilage, and we just do the camouflage of the dorsum. Okay, and another injection way, another injection technique, not with cannula, but for radix injections. If you want, you can use needle. We generally use 3.5 concentration and 27 gauge needle, aspirate, and then give really small amounts. Each time 0.1 ml to inject here. But you have to be sure that you are on the bone, just perpendicular injections, touch the bone, inject, aspirate, and inject very little amounts. Maybe you can inject 4 or 5 times, but each time just give 0.1 ml and always push your fingers, your non-dominant fingers laterally to prevent from migration and any arterial complications. And that's all. Okay. And this is a result with cannula, entrance point from here to the total dorsum, just to prevent the hump. And supratip injection and the radix injection, an immediate result. And this is a patient after rhinoplasty. There is a deformity in radix, so he didn't want any operation, and we did filler in the radix 2.5. You can use 3.5 also here, but this is post-surgical case, so I decide to do 2.5. Okay, and this is a broke nose. There is a really serious deviation, and you can inject the left side 2.5 really deep on the cartilage surface and the bone surface to have a camouflage on the broke nose. Now she doesn't need any operation. You have to be very careful. Just introduce your cannula from here and go really deeply, aspirate, and do your injection. I never use needle in lateral walls of the nose, never. I use needle just in the radix, sometimes in supratip area. Here, another deviated nose. If you inject the other side, the left side, here, you can hide the deviation like this. This is much more better nose, so you can hide the deviations also with this. And this is radix total augmentation with 2.5. This is Arna's case, and it is really a really good material to do these injections, because there is no swelling. You see, it is just like your bone, no swelling. It's a hydrocolloid filler, so really gives really good contour, shaping, and adds here definition. So really good filler. And this is the immediate result in an Asian patient, the whole dorsum augmentation, and this is 7 months later. No swelling, no swelling. It's really big advantage. Sometimes we use this filler for functional cases. Like here, there is an alar depression. After a rhinoplasty patient, we just inject into the nasal wall from inside the nose. But this is really difficult injection point. So you have to be really experienced doctor for this kind of injection. So I don't advise you to do this kind of injections. Just stay in the midline. Okay, and after all injections, take the nose. Okay, for injection protocols for nose, the volume of the filler varies depending on the size, but we never inject more than 1 ml in one session. So it's better to inject not too much. We don't like over corrections, you know. And the concentration of the filler varies depending on the skin quality and the thickness. So you can use 1.5, 2.5, or 3.5 concentrations. It depends on the patient's situation. And if you want to touch up, wait 4 weeks for touch up and corrections. 4 weeks you need to see the result. And especially for revision rhinoplasties, be careful. If there is any surgery, there is some problem because the tissues are traumatized and devascularized. So you have to be very careful. You have to dissect and release the dense scarring and adhesions, and so you have to create a space with your cannula, and then you need to inject. And always we compress our non-dominant fingers to ophthalmic anastomosing vessels in the lateral walls. Inject as much as deep plane, suprapericondyal or supraperiosteal plane, we call it subsmas, and stay at midline. Sometimes I saw that some doctors using cannula with flexible cannula. We don't advise flexible cannula because you don't know where you are inside. Sometimes you think that you are in midline, but the tip of the cannula is going laterally. So I generally use 22 gauge blunt tip cannula, but rigid cannula. Why 22? Because I can see it from outside, that where I am, if I am in the midline, it's really easy to see with rigid cannula, 22 gauge rigid cannula. And if you use needle, we always use 27 gauge cannula, but if you inject 1.5 or 2.5, you can use 30 gauge needle. In some papers, they say that they believe that 30 gauge needle is much more safe than the thick needles. Each time inject small amounts and slowly. And if you use cannula in a retrograde injection technique. And you have to be very careful in the tip and columellar area, and you have to watch the skin. If there is any blanching or any pain, you may suggest that any vascular compromise, you have to be careful. And I have to say something else, Valentino.
Yep. Go ahead.
This is the injection technique with Algeness. We have different injection techniques with maybe with HA, but I don't talk about them. I only talk about the Algeness injection technique. So we may have.
It would be interesting to know, because you have a large experience with HA, okay, and then you did a lot of HA injection as well before Algeness. Maybe you still do some, I don't know, on some patients. But what's the difference you notice? Why today you prefer Algeness? There is a reason for it. It's and then you used Algeness before to become our clinical support director. Then why is that? Why is it your favorite filler for the nose?
Because when you feel nose, you don't want any swelling, you don't want any edema. And in HA, you so many times you see some swelling and you see some migration, and not you cannot get good definition. So what we need that hydrocolloid injection to get a very good definition, to get very good contouring and projection without swelling. And we need a safe material when we contact with bone and cartilage. So when I look to the market, there were only one filler in the market that gives us to these advantages: hydrocolloid and safe on bone and cartilage surfaces, and no granuloma. These three advantages are really important.
Thank you. We have a question. After rhinoplasty, how long do you wait before injection when there is a secondary correction to do?
Yeah, really good question. If you wait 6 months or if you wait 1 year, you can do operation. But sometimes patients come to you, they have an operation somewhere, and they don't like the shape, and they want to correct it. And I said, you have to wait at least 6 months. It's better to wait one year to correct some deformities for the second operation. But they say, how can I go out with this nose? So you have to do something for this. So after 3 weeks or 4 weeks, I can do some injections for this kind of patients. And believe me, if you do corrections in the early stage, you may correct permanently the deformity. I have a study with this, and I am collecting the patients now, the series.
Then you say that 4 weeks after surgery? 4 weeks after surgery, yes, you can do corrections?
Yes, 4 weeks after surgery. But always, I try to dissect where I am injecting and try to do it with cannula, dissect the fibrosis, create a space, and inject, and then leave it. Because I have some patients, I am follow up them for 3 years. They came to me a really big deviation or deformity. I said that yes, you need operation, but it's really early now. We can do camouflage with fillers, and 1 year later we can do operation. And for 3 years, they are still good, no problem. So in early stage, if you do your injections to correct some deformities, it may be permanent correction.
Okay, thank you.
I am following up my patients for 3 years, they don't need any operation till now. So it will create a space there, and the fibrosis and the wound healing just replace the deformity, because the Algeness, you know, has a scaffold effect. And actually you are injecting a scaffold there. So
yeah, that's great.
So you, in healing process, you restore something there.
Yeah,
That's
amazing. Thank you.
Thank you. Other questions regarding this first part of the webinar?
Valentino, no more questions on the chat.
No more questions on the chat. Okay. Omar, you can go ahead with the second part of your presentation.
Okay. Let's focus temple. Temple is a really important area. Too many patients in Turkey now wants to replace the volume, the loss in this area. The volume loss depends on the muscle contraction and resorption of these soft tissues in this area. But this area is really anatomically difficult area. I will tell you in the slides that there is not too much safe place here. So the most safe area, where can it be for injections? Very deep or very superficial. You have to be very superficial, or you have to be very deep. And this is one injection technique. And we inject here. This is the suggested injection zone here, 1 centimeter up to the edge of the eyebrow, and 1 centimeter below. This is the suggested injection point in one technique. But in this photograph, the superficial temporal artery goes under the hairline. No, it's not true. So many times it's going from here. So you have to be very careful if you try to inject in the mid-level, in the subcutaneous tissue, because it goes from here. It has different patterns in different nations, different patterns, but generally it goes from here. So this point, not here, it is never inject into the lower part here, the upper part here, 1 centimeter up and 1 centimeter down, and this is the suggested injection zone. I generally use in the supraperiosteal plane 3.5 concentration, because the Algeness 3.5 has really good projection and G prime and doesn't migrate. This is very ideal filler, in order to me, the best filler for temple. No migration, very good G prime, very good projection. So the best, in order to me, the best filler in temple is 3.5 agarose gel. You have to inject slowly. You have to watch for the arteries, because there may be some superficial veins. Don't touch them. Just inject behind them. And after you finish your injections, don't do strong massage, gentle massage, and warn your patients. There may be pain for a few days, especially during mastication. There will be some pain. They can get some paracetamol, no problem. But as I said, here with needle, we touch the bone, aspirate, and inject. This is the main technique. Or you can superficially subcutaneous injection, but I will not talk about this because this is a different technique. And in order to me, in my practice, the supraperiosteal one-shot injection technique is much more easy and effective with Algeness 3.5. So this is what I mean, the different patterns here. So sometimes it's really down here. So you have to be careful when inject here in this temple area. You see, this is the entry point, but in this patient, they didn't do injection on the bone. They inject to the deep subdermal plane. If you inject here in deep subdermal plane, you can easily injure the superficial temporal artery, like here. The necrosis here. This is superficial temporal artery branch, the temporal branch. You see, there is 3 layers: the skin and the bone. There is 3 layers, but too many layers, but there is 3 artery. One is deep temporal artery. It's something here. One is middle temporal artery. The other one is superficial temporal artery and vein. This is superficial temporal artery. So you always have to inject here on bone surface. But if you want to inject deep subcutaneous tissues, be careful to this superficial temporal artery. If you are on the bone surface, it's really difficult to injure this this artery because it's more superficial. But you may injure deep temporal artery if you inject here. Or then you have to stay in this area. I will show you with a video. You see, you have to be here. This is the frontal branch of superficial temporal artery, and these are the deep temporal arteries. Okay, this is your suggested injection point. Okay, this is the point, and you have to be careful. These are superficial veins. If there is superficial vein, just a few millimeters above or under the vein, don't injure the vein. So just look to the veins, superficial veins. The injection technique is deep injection, supraperiosally. The injection technique is big bolus. This is the only area that you can inject big bolus, the Algeness. Why? It is fossa and very good coverage of skin and muscle. So there is no lump. So you can inject big bolus only in this area with Algeness. Indicated product is 3.5. The needle is 27 gauge needle. The amount, it depends. Sometimes half shrink here and half shrink the other side, or one here and one the other side. Generally, I use the whole shrink, 1.4 ml. Always aspirate before injection. Algeness is the safest filler when you inject into the artery, but we don't know what will happen in the end arteries and the end of the artery. So always be careful and watch the arteries. And you can press your finger, digital press on hairline, not to migrate up. And don't do strong massage because it can go down and lose its volume. And warn your patients for a few days, there may be some pain. Okay, let's see a video about this. So this is the place that we will inject. There is a superficial vein here, so we have to be careful. Okay. Normally, each patient has different anatomic variations. Don't forget. Normally, in this patient, you can think that the border is here, but when you palpate with your finger, you can see which area is the correct injection area. Okay, now you press with your finger to the hairline. You just touch the bone. Okay, you touch the bone. You aspirate, and then this is 1.4 ml and 3.5 concentration, and we do big bolus injection slowly to this area. There is no pain. There shouldn't be any pain. If there is any pain, just stop. It may be a vascular compromise. So slowly you inject. Then you finish your injection. Generally, there is no bleeding. and no pain. When you finish it, just do gentle massage, not strong massage. If you do strong massage, it will go down, so you may lose its volume. Okay, now it's finished. If you need 3 weeks later or 4 weeks later, you can do another another injection. After massage, you can see the veins here, superficial veins. This is after massage. Okay, really plain surface, no irregularities if you inject deeply. If you inject superficially, it's a different technique. I can talk it later if someone wants it, how you inject the superficial layers. But for Algeness, this technique is I think the most suitable technique for you. Okay, this is an injection patient in the temple area, and I think it's 3.5, yes. And this is another patient with 3.5 each side, 1.4 ml. Here injected 1.4 ml on this side. Okay. And in all kind of Algeness injection, asepsis is essential. And use, if it is possible, use sterile gloves and gauzes, because when we finish our injection, we do molding, we do some massage, so we are afraid from contamination. So we have to work in asepsis conditions. So be careful to work in asepsis conditions. After procedure, this is standard for all kind of fillers. What about the complications? The biggest complication with HA fillers in these areas are vascular compromise. As I told you before, we did a study in Turkey, in Izmir University, and we saw that in rats, we saw that it is really difficult to obstruct the artery with agarose gel. Even we inject into the artery, the circulation goes on. The reason is it is very small particles. These agarose gel are, I think they are approximately 5 micron. So very small particles, and the circulation goes on between these particles, and it's really difficult to obstruct vessels with Algeness. And in animal study, we did it in Izmir. In the animal study, there were no necrosis, even we don't treat with any antithrombotic agent or vitamin C. We use vitamin C in one group. We use urokinase antithrombotic agent in one group. We use vitamin C plus urokinase in one group, and we use only saline in one group. And in saline group, the necrosis of the flap was very low. In the urokinase group, only urokinase with urokinase is nearly totally survived. The flap was totally survived. Why? Because why we use antithrombotic agents? Because even they are very small particles, they can aggravate the thrombosis. So if you use only antithrombotic agents, you can prevent from vascular complications. But even if you use antithrombotic agents, sometimes in the end artery, these particles can go to the end of the artery and may have some small problems. So you have to be careful, always careful not to inject into the vascular structures. Okay, the very standard, you can use antithrombotic agents, you should use, and it may be aspirin, and you can inject inject low molecular heparin in the filler area. You can wash out with low molecular heparin. You can use hyaluronidase because hyaluronidase can increase the permeability of the vessels, and antithrombotic agent can affect more. And you can do warm compress. You can use nitroglycerin patch. We did these treatments in HA complications. And if there is too much reaction, you can use prednisone. Okay, and you can visit Algeness training website and training.algeness.com. And this is free for doctors and only for doctors, and really free registration. You can see our training tools there, and you can download the Algeness photo application from this website. Thank you for all, and please do not hesitate to call me. This is my personal WhatsApp number and mail, and also you can ask everything from this mail, clinicalsupport@algeness.com. Please don't hesitate to contact us if there is any kind of problem. Thank you very much for your attention.